going to be, even though you've not heard about all of these aspects that were discussed before, I'm just actually going to present a study that has been completed from my laboratory and sort of lead you through, sort of give you a broad perspective of how you can use metabolomics. So for the half a day or so now, you've heard that there are many different methodologies you could use, and you can screw up in many different ways in terms of sample preparation, and you're wondering at the end of this, you wonder that how the hell am I ever going to do a study, a real study? And I can actually, the data I'm going to present has many issues with the way we actually designed the study. And I just want to say, tell you that while we use certain strategies to kind of optimize information that we can get. So those of you that have kind of dreaming of using some of your freezer samples that have been stored away for 20-some years to do some studies, this is a living example of how that can be done. Many flaws in sort of the overall design, yet you could use that for meaningful information. I will point out each one of them as we talk about. So the disease I'm interested in, so the first question is that, so this is going to be a clinical study that I'm going to talk about. And so the first question that always comes in is that why do a clinical study? Is there not enough markers already available? So why do we need new biomarkers? And the answer to that is that medicine is relatively imprecise at this point. And this actually comes in as a quote of one of famous physicians, William Hosler, who basically said, medicine is a science of uncertainty and art of probability. Many things in medicine is basically based on the art of medicine. We basically figure out that, okay, this person may need more aggressive treatment based on this, and this feature, but it's not very precise. Not all diabetics develop complications, for example. Not all people with complications develop complications actually progress. We don't have a good way of actually assessing either diagnostic or prognostic information. And that's the reason why we do these biomarker studies, to kind of better understand this. So the disease my laboratory works on is essentially we work on diabetic complications. And as you know, the diabetes affects many different parts of your body. The specific disease we are interested in is kidney disease. And I happen to be a kidney physician, so we do have I do see patients with this problem, and we still are struck by the fact that we really are not able to predict who is going to progress and who will need more intensive management. So if you think about kidney disease, this is the dominant cause of kidney failure in the United States. The incidence of kidney disease is increasing, and diabetes is the most common cause of end-stage kidney disease, which needs dialysis. Now, you may ask, why do I care about this? That's because 2% of the GDP of the United States is spent on kidney disease. This is a GDP of the country, not actual Medicare expenses. So it's about 18% of Medicare expenses are for kidney disease, only for 60,000 patients. So this is the most per capita expense per disease. So that's why we care about it and try to figure out why this would be something that may be how we can identify new biomarkers in this disease. Let's see if this would work. Should I point here? Oh, it did. Okay. So the pathology of the kidney disease is basically that this is a normal kidney filter, that actually glomerulus is what we call this. And essentially, it has very little of this pink stuff, which is fibrosis and advanced kidney disease. And this is essentially scarring. It's diabetic glomerular scarring. But what we're trying to understand is that how do you go from here to here? Not all people with diabetes go from here to here. Even the people that have early evidence of the disease, meaning that they have some evidence of some disease process at this point, not all of them progress either. But we direct our treatment strategies the same to everyone with diabetic kidney disease. So the idea is, can we find new biomarkers? I'm not sure. Okay. And the current strategies currently that are employed include blood sugar control. This is known to reduce albumin or protein excretion in the urine. This is the initial stage of the kidney disease, but its role in progression is not clear. So once you have documented kidney disease, does lowering blood sugar control really change your outcomes? It's not entirely clear. Degree of protein in the urine does predict progression. Some lipids do, maybe. The use of the drugs, these are the major drugs that are currently used, and this has not changed for the past 15 years. So it's essentially the same drugs that we are using for blood pressure control. And really what they do is they delay progression, and it's thought to be over and beyond the effect on blood pressure control. So the aims of this particular, our hypothesis, was basically to see whether we can determine markers that are associated with early kidney disease and type 2 diabetes, and whether we can evaluate association between plasma markers and the progression to end-stage kidney disease, which needs dialysis. So this is sort of the broad idea behind our study. So the first thing we asked was, here, so which place am I supposed to point it when I'm progressing? Oh, here you go. Okay. Yeah, it's kind of acting up. So the first question we really asked was, can our biological questions be answered by metabolomics? That's an important thing for you to consider. Not all questions are answerable by metabolomics. So the first thing was this. So when we asked, okay, fine, diabetes is a metabolic disorder, right? So you think that metabolomics may help in diabetes. But also there are other things that made us think that this may be relevant. So I think this has decided to sabotage me today.
So you have to be on the other side.
Oh, okay. So that's what it is? Okay. So I'm trying to see it and talk. So the term uremia is used to loosely describe the illness accompanying the kidney failure. And it is thought to be due to accumulation of so-called middle molecules, organic waste products. These are called the uremic solutes. And all of them are virtually small molecules. And this should be approachable by metabolomics. So there are about 160 plasma retention solutes that accumulate in the subjects with renal failure that have been identified by this consortium, and all of them are small molecules. So there's some evidence to suggest that with accumulating of worsening kidney failure, you accumulate the small molecules. So therefore, potentially, metabolomics may be an approach that you could take to come up with biomarker discovery. So the question we had was that what are the factors to consider while designing this metabolomic study? So the first thing was that do we have a real good patient population for us to do this? So the first thing, the study population and the study design. So as it was talked to about today. And I will actually going to talk to you about this one cohort that we had. This is the Jocelyn diabetes cohort. One of the biggest advantages of this cohort is that they have very well delineated patients that were deemed as progressors and non-progressors, meaning that these people developed kidney failure and needing dialysis, and those who did not, who were diabetic. They're very well characterized, longitudinal and long-term follow-up for plus 20 plus years. So really a very robust cohort of subjects that were available to us. So what are the problems with this study? The cons are basically the small numbers. So even though, for people to follow up for 20 years, the number of subjects was relatively small. There are many other confounding variables we needed to think about. What about the age at the time of when the blood was drawn, sex, duration of disease, hypertension, lipids, renal function at baseline, medications, etc. So now you're talking about multiple different variables that can affect the study and small numbers. Right? So I always worry about studies in which the number of metabolites that are measured or number of variables that are measured are greater than the number of the study itself. So you have 3 mice and you're looking at 1 million metabolites. So there's always a problem with that type of analysis. So whenever you're looking at small numbers, the confounding variables become a big issue. So the second thing that we've confronted with was what do we analyze? So the things that were available to us were the biosamples. So they were plasma and urine that were available. And these were baseline samples, meaning that these were taken years prior to the development of the renal failure. So we could actually do this longitudinal follow-up. The advantages was basically that. That is a hugely powerful study because of the fact you have samples available that were collected 20 years ago. The disadvantage is that the plasma was non-fasting. So we talked about the effect of diet in determining the plasma metabolome. So when you're doing a metabolomic study, There were patients that would have potentially consumed their lunch like an hour before their clinic, and some would have taken 7-8 hours. So it was all very variable and random. And so this was a major issue. The urine was not stored appropriately, and people talked about this morning about bacterial growth to be a concern, sodium azide use. So we actually kind of tested for some of the usual common things that are found in the urine. I mean, citrate is found in abundance in the urine. When we checked for citrate in this urine sample, there was nothing. So we know that it was completely degraded potentially with storing. So that was one of the issues we faced. So we decided, because of that fact, we're just going to use plasma, with the caveat that this is going to be a non-fasting specimen. So the third question is that what type of metabolomic experiments do we want to choose? Is it going to be targeted or untargeted? So in this scenario, what we were really looking for is sort of a bird's eye view about the entire metabolome of predictors of progression of renal disease. So because of that, we decided to do this untargeted approach, as opposed to a targeted approach where we'll actually pick up a few areas in which we want to look at more detail. So the cons of this approach, again, are the small number of subjects. And we are with the idea that we are looking at this untargeted approach of studying hundreds of different metabolites, a small number is going to reduce your power of actually seeing definitive changes. And the multiple comparisons. So as I talked about, there's numerous clinical outcomes that can affect the progression. And so are we going to find something over and beyond what is already known? In which case I told you about the starting kidney function and the albuminuria. So is there anything more than this that we can find out from this metabolomic experiment? So finally, the issue is the variability of the analysis itself, right? So you talked about the technical variation, the diet, the non-fasting state, degradation over time, because we don't necessarily know the plasma is a better thing because it's still been collected 20-some years ago. So one of the things we did in the study was that we were able to really focus on the study design to minimize the clinical variables. And I think this is very, very critical. Even though I told you about all of these problems, this is probably the main reason this study actually worked, in that we were able to match the clinical criteria very, very precisely and closely. So first of all, there were about 40 individuals that were deemed non-progressors, and ESRD progressors were another 40. And you can see that most of these are non-significant. So the duration of disease, age, body mass index, A1C, lipids, antihypertensive medications, everything is pretty much non-significant between the two groups. The only two things that were significant was the amount of protein in the urine. People that ended progressing had more. We talked about this as a marker for progression that is well known. And the initial kidney function, estimated glomerular filtration rate, which is sort of like a percentage of how well your kidney is working, essentially there is a difference between these two groups. Even though they're sort of relatively normal, you're talking about 85 and 90 GFR to be around normal. But still, there is a difference between these two. So these are the only two variables that are different. What is interesting is that the people that progressed tended to do it earlier. It took 7 years they tended to reach end-stage kidney disease. And the length of follow-up for people that did not progress was actually much longer because they did not progress. And so you just want to make sure over time they did not have that. So essentially, it's a very well-matched cohort, and this was a critical reason why the study was successful. So this is sort of just a screenshot of the type of metabolites you get in an untargeted analysis. You're looking at every single metabolite that is available, that is actually present. And people are going to go through in more detail how these analyses are done. But in general, this is sort of the retention time of your chромatogram. You pass your sample mixture through a column, and this is the retention time on the column. And what the mass spectrometer really measures is the mass to charge ratio, and the charge is typically 1. So essentially, you're looking at the mass, and each one of these points are mass to charges are different metabolites that are actually coming over the span of time. And these are two different chromatographic techniques, and essentially, you're finding this littered with metabolites. So this is a very, very rich data set that you have numerous metabolites in. So the question becomes, again, as we talked about, it's only 40 subjects that you're measuring this in. And here you have thousands, literally, of number of metabolites that you actually have. So the question, issue 4, is that too many variables, right? So too many outcomes with untargeted platform, more than 10,000 features if you combine the Helix platform and the reverse phase platform. And yet there is a very, very small number of subjects. So unless you're going to have a massive change, and when you do statistical analysis to correct for multiple comparisons, you'll have a very hard time finding differences if you have this many number, even though the differences may be real, just because of the stringent statistical criteria. So one of the first things we did was, again, we limited the known to known or named metabolites in the library. Very first step, just cut it down to only the limited to the known metabolites. That actually cut it down to 445. So the rest a lot of them are unknowns, which is not entirely clear what they are. They could just be adducts of some sort, but we are not entirely sure. So we eliminated a lot of the master charges by this. Now, the downside of this is that there may be an unknown metabolite that may have a greater biomarker potential, but you're ignoring that. So by limiting the number, in some ways, you're actually ignoring something that may have a very high potential. So that is a downside of this approach. The second thing we did was we limited to compounds detected in at least 80% of each group. So in other words, if a compound was detected only in about 10% of one group, like only 4 subjects, that is gone. That is thrown out. So it has to be present in majority of the patients in both groups for us to say that this is something that we want to consider. So that, again, cut it to another half, and we come up with 262 compounds. Now, then the third issue is we talked about was the next issue, number 5, is the sample collection issue. So we talked about these were patients their prandial state was unclear. Most of them were postprandial, so they were coming in the afternoon to clinic. And some of them could have been fasting, so it's unclear what the situation was. So how do you handle that? So the way we handled this was basically, and the other issue is also the stability with storage. So as I said, some samples were 20 years in the freezer, and are we actually missing something with this? So it's the sample store. So the question was, how do we actually handle this variability? So the answer, what we did was, we had samples on a subset of patients that was done the very next year. So there's a baseline sample done 20 years ago, then there's a sample that was available year 19 and year 18 in some subjects. So those samples were available, we reanalyzed those samples to limit the analysis to compounds that are reliably detected in both of those samples. So in other words, if there's something was prandially mediated, it is very unlikely that 3 years down the road you'll get a good correlation of that particular compound, because obviously the person would not exactly would have replicated the same thing. And the other issue is basically if you have sample storage or degradation issues, it is again unlikely that you have 18 years and 20 years, you may have a big difference between the samples. So we actually limited the analysis to only those who were reliably detected in both the samples. So this is the data from that work. So when you look at amino acid metabolites or carbohydrates or lipids or nucleotides or other metabolites in the untargeted platform, you can see that the reproducibility is variable. So some of the amino acids are actually very poorly reproduced, and some of them are very highly reproduced. And it's pretty much similar across the board. If you look at carbohydrates, those are the ones that seem to be mostly reproducible and only a little bit here. But in general, there are both ends of the coin. So we came up with certain statistical measures and determined that the R value, at least the correlation coefficient between these two measures in the same individual separated by about 3 years of time, needed to be at least 0.4 for us to actually say that these are the metabolites we're going to take into account. So this again lowered the number that we are going to analyze. We call them the stable metabolites. These were called so-called stable metabolites. So those are the only thing we are going to take it for analysis, and we ignored these. Okay, so a rank correlation coefficient greater than or equal to 0.4 between the paired sample was used to distinguish metabolites that are persistent versus transient concentrations. And by this criterion, only 119 of the common metabolites tracked well over time when individuals thus were considered persistent. So we started at 10,000, we came all the way to 119 for our analysis. So really now you have the power to really determine whether this metabolomic profile actually predicts changes or not. So this is sort of some of the summary slides. Busy slide, but basically what it shows is that the total number for the lipids, for example, or about common metabolites are about 126, and the stable metabolites among them are about 51. And the amino acid metabolites, the common metabolites, were about 67, among the stable were about 35. And so on and so forth. So those that were associated with end-stage kidney disease came from each one of these metabolites, and essentially we came in roughly about 49 of the common metabolites and about 28 that were stable over time. So really that predicted who is going to progress to end-stage kidney disease and who is not, based on baseline samples, and these were tracked over for the 7 years henceforth. So these are some of the amino acid metabolites. Basically show this is a sort of traditional volcano plot. You're looking at fold difference here. This part of the curve indicates the lower for ESRD risk and higher in subjects with ESRD. And you can see some of them are markedly elevated. And these are the usual suspects that we normally see. So statistics has not been discussed, and it's going to be discussed down the road, but I just want to show just a slide of how you may try to interpret this type of data. What you could do is basically ask the question, just do a univariable analysis, which is basically ask the question, what are the odds of this particular metabolite predicting somebody's going to progress or not? And this is so-called odds ratio, what most clinical trials are done. And then you can adjust by the hemoglobin A1C, which gives you the glucose control, albumin excretion, which is the proteinuria in the subjects, and the starred eGFR, which is the degree of kidney function. And then ask the question, does this metabolite hold if you adjust for all of these variables? And do all three combined here. And what you find is that basically this particular group of metabolites, which is basically the amino acid metabolites, actually holds even after you adjust for all of these variables, suggesting that these are true biomarkers that you could use potentially in clinical practice. And this is another group of metabolites called uremic solutes. As we talked about, these were the things that actually accumulate with decreasing renal failure and renal function. And then basically you see the same pretty similar picture here. And I'm just going to skip this and actually show the same thing. Basically, you do a univariable and multivariable analysis and essentially show that these metabolites actually predict progression very strongly. Okay, and there was a question that was asked. This is basically just showing that how you could do clustering analysis, which is again will be taught, that you could actually find out how these metabolites group with each other. So a question was asked in Charles's talk about the value of doing a targeted platform after an untargeted platform. I'm not sure who asked that. I just walked in a little bit late. So we actually did that. So for all the 35 metabolites that were initially identified as predicting progression, we did targeted analysis on all of them. First of all, to figure out what the concentration was, because we could then report it as a clinical study, but also to see how good the untargeted platform was. It turns out about 2/3 are reproducible. There are some, like uracil in this instance, and indoxyl sulfate and hipurate that did not. Once you do a targeted analysis, this falls out. So these were not actually statistically significant when you do a targeted analysis of that. So basically, what it again turns out is that the higher the concentration is of something, is more reproducible it is likely to be. So the lower the concentration of some of these things, the less likely to be reproducible they are. So I think it is definitely reasonable. In fact, I would mandate it that you do a targeted analysis after an untargeted analysis before you actually come up with a biomarker pattern. And the rest of these guys, actually, we were able to validate it. So this got messed up, but I guess it's fine. So basically, we were able to come up with a pattern of metabolites in this proof of principle study by global metabolomic profiling by Untargeted for biomarker discovery, and then validated with a targeted approach. In association of the uremic solutes with disease progression were independent of relevant clinical characteristics. And the absolute what was very interesting was that the absolute concentrations of these metabolites were actually within the normal range of what was being reported in the literature. It is just at the higher end of the normal range. So I do think that this type of a methodology is very valuable in biomarker discovery. And as I pointed out, despite all the issues that I've raised, you can actually make meaningful interpretation of the data if you think through all the issues carefully. So I will actually stop there and take any questions. Yes?
You mentioned in the targeted validation that the metabolites that are at the lower end fell off and were not validated. Mm-hmm. Does that have anything to do with the length of time since you measured them? Is it possible that you have the way they were stored for 20 years that you can no longer measure them and they're not detectable?
So these were detected in the untargeted platform. Uh-huh. Okay, and then we are using the same sample to do a targeted analysis of those compounds. So the length of time between the two analyses was just a month or month and a half. So we don't think that would have had a major impact. It is just that actually, it is not that they're not detectable. There is no difference between the levels if you quantitate it if it's using a targeted platform. Yes, you have.
My question was going back to how you sort of designed the study. Was the remarkable lack of difference in many characteristics between the two groups? Right. Did you select out people from the progressors and non-progressors, or was that just dumb luck that they turned out to be that
No, actually,
close?
it was it was a nested case control design because of the fact we were concerned about this. So the actual numbers that are available for the people that progress and did not progress, it's actually about 3 times the size of this overall cohort. So it was selected in such a manner that it was equal for the discovery part. So now if you want to go back and validate it in the other cohorts, you can, but using a more targeted platform, using only the metabolites that we think are relevant. Yeah.
Great talk. So your study have discovered several metabolites that are associated with the progress of renal disease. Right. So have you done any analysis to see any connections between these metabolites? What is the mechanism behind this?
Right. That's a great question. So, obviously in human studies, you get only association data. You can't get causal data or mechanistic data from these. So for that, you have to go back to animal models and actually really interrogate these pathways and see where you can find what the potential mechanisms of these are. Now, what we think is, as far as the uremic toxins are, we think it is related to early tubular dysfunction. So as I said, the concentration of these metabolites are still within the normal range, the so-called normal range that has been reported. It is just at the higher end of normal. So there is the defects are quite subtle. So Anna Matthew has been looking at some of these metabolites by flux analysis in the mouse model and shown that there is a very clear-cut early defect in diabetic nephropathy that occurs in the tubular function and excretion of these metabolites. So that's probably the most likely mechanism. But then, that's for at least for the uremic toxins. But for amino acids and other things, you have to go back and look at this in more detail in a relevant model. Yeah.
Great talk. So those are retrospective studies, right? In a sense, or cross-sectional, you call it?
So this is a case control cohort, but the event is prospective. So basically, the samples have been collected at baseline, and you're looking at data prospectively. So the event outcome is prospective, but it is a retrospective analysis of the baseline samples.
So my question is like a cause effect relationship. Let's say some of the metabolites is defined by genetically or like after as a consequence of the disease or not. So let's say, should we or can we design, let's say, looking at the metabolites, divide the group into 2 groups or 3 groups, and to see how in the coming 10 years or 20 years do we differentiate that result of the, progression into the of the complications or not. So try to really define that predictive value of that each metabolite.
Right. I think that those are good things to do. I mean, in this study, we kind of limited the metabolites we are going to analyze for things that don't change with time, at least in the same individual, it did not change in 3 years, within 3 years. Now, there are a lot of related metabolites in that particular tree, which did not, as Charles was talking about, just slightly fell off the cutoff or the p-value. And so that may actually indicate a more broader aspect of amino acid metabolism regulation or nucleotide metabolism regulation. And those would be quite interesting to explore, sort of more prospectively in newer cohorts and see how, are these changes fundamental and are they really predicting progression? So I agree with you. I think these will be good, interesting things to do down the road. All right. Thank you.